Well, good afternoon, everyone. It's a real pleasure to be here this afternoon. Thank you very much for the invitation. Absolutely right. This is our latest piece of research. I'm really delighted to share it with you today. You are the first audience who we're sharing these insights with, which is great. I'd like to pitch that you're a privileged audience to be receiving these, but as my colleagues back home pointed out, that also means that you're the guinea pigs. So I guess it kind of depends whether you're a glass half full sort of person. I should flag that this talk is not going to include blockchain, digital technology, the latest cutting-edge digital health, nor is it going to talk about diagnostics, genomics, genetic editing. I want us to take a step back now. All of those points are really important, but we need to think about something more foundational and fundamental. I've got a lofty ambition that in the next half hour, I would like to change the way that you think about the nature of the work that we do in healthcare. And I'll explain a little bit more about that as we go along. Stay with me. But first of all, I want to ask a few questions to try and set the context for this. So I'm sure you didn't think you were going to get tested during the quiet afternoon after lunch, but I'm just going to ask you to put up a show of hands to help me here. First of all, put your hand up if in your own organization, right now, you can think of something objective, something that you would like to fix or improve in your healthcare organization. Put your hand up if you can think of something right now that needs to be sorted out. Okay, that's nearly everyone, which is great. I have to say, for those who didn't put their hand up, either I would like to come and work in your organization, or maybe you haven't been into work recently. We'll gloss over that bit. So, for those people who have got something in your mind that you would like to fix, to improve, put your hand up if you've actually managed to deliver an improvement last week at work. Did you actually manage to fix or sort something objective? I can see maybe 3 or 4, 5 hands in the audience, very few. Okay. Final question. Put your hand up if you work in an organization that has coached or trained you to identify problems, but to then fix them yourself. It's empowered you, it's given you the time and space to try and build improvement into your work every day. Put your hand up if you work in an organization like that. A few hands, okay. That's really positive. So I should say, I'm really pleased you didn't all answer yes to all of those questions, otherwise this would have been a really short presentation. But let me now try and explain to you why all of that is important. And before I do, I want to just give you a bit of context about my work. So I work for the global healthcare team at KPMG, but that's not where I started. I qualified in medicine back in 2003 and spent 12 years working in the National Health Service. And I got a really good interest in the sort of problem solving. You know, it was in my nature, which is probably why I ended up training in general surgery. Thank you. I was someone who really wanted to try and fix things, and I got very frustrated that I was working in a healthcare system and organization, I'm sure as many of you are, you see a lot of problems around you, but don't necessarily have the ability to or able to influence any of that system around you. It gets very frustrating. You feel very disempowered. And at the end of my training, I stepped out to undertake a fellowship. I worked with Atul Gawande's charity, Lifebox. I spent a lot of time working in sub-Saharan Africa, particularly Sashika in Kigali, if any of you are familiar with the hospital. And I was really surprised because although the magnitude of the challenges was obviously much greater, I saw the same disempowerment on the front line. I saw people who were even more aware, I think, of the multitude of problems around the service and system around them, but were equally unable or not empowered to try and fix them and sort them themselves. And I realized that if I wanted to make this my area of work, I was going to have to do something more than being a jobbing doctor, which is how come I ended up working in the global healthcare team. So I'm very fortunate to spend a lot of time traveling, looking at different health systems, and the dots on the map represent KPMG's healthcare offices, so not just KPMG offices, but offices around the world that do healthcare. In the last 18 months, I've visited 25 of these, and it's a real privilege to be able to look under the bonnet of different healthcare systems and different healthcare providers, see what best practices and see what works. And one thing that I've commonly noticed is that in high-performing healthcare organizations, they work differently. They build continuous improvement into everybody's role. Now, this is Kilimanjaro. Has anybody climbed Kilimanjaro? Put a hand up. I can see 1, 2. Okay, so I'm going to give you a bit of free advice, and it's very rare that consultants do this, so listen carefully. My free bit of advice is don't climb Kilimanjaro. And I'll tell you why. So 3 weeks ago, I was up on that plateau just there. And you can see we're well above the clouds. This was about 4,000 meters. It took me 6 days to get there. And I reached the rim of the mountain and developed high-altitude pulmonary edema. I got severe altitude sickness, and having got 6 days to get up there, 6 hours later, I was in the hospital at the bottom of the hill, one of the main hospitals. And I got fantastic care at that hospital in Tanzania. I absolutely make that clear. Fantastic care. Probably one of the world's most experienced hospitals at dealing with severe altitude sickness. Very good quality care, looked after very well, and I should say as well, the food was far better than the National Health Service. I was really impressed. But has anyone else here had any experience in the last year or so of being a patient in hospital? A few hands going up. It changes things, doesn't it? You know, we spend all our career, we talk about patient centricity, but when you're the one in the hospital bed, suddenly being the patient becomes very centric, and you get a real idea about what needs to happen in medicine, communication, empathy. But the other thing that I saw in the hospital bed was just observing the workflow, how things were organised, how I was shuffled around, how I was moved, and it was really interesting because that was no different to any other hospital that I'd been in anywhere else. The difference was that I was bringing a fresh pair of eyes to what I was seeing, whereas the staff were just working, doing what they were always doing. Now, I identified there was a lot of waste in the system. And what do I mean by that? So one of my biases is, I think with my clinical background, I don't really like management mumbo-jumbo. And when people first started talking to me about waste in healthcare, I thought of the sluice room. I thought of the sharps bin. What I didn't think about was exactly what I was seeing in front of me while I was in the bed in that hospital. Let me give you some examples of what I mean by that. So every step of the journey, I'm sure this will be very familiar to people who've worked in low-resource hospitals in sub-Saharan Africa, every step of the journey, there was some paperwork to fill in. Carbon copies, old ledgers, relatively unclear how that was contributing and adding value to the care process and pathway, definitely over-processing involved. I was shuttled around quite a lot, actually. The patient flow of the hospital wasn't that good, and it meant that it took a lot more time to get me through the emergency department than it should have done, which meant that actually patients were waiting longer beforehand. And certainly waiting was a big feature, but there wasn't anything happening while I was waiting. The blood tests weren't done early so that they were available later when the decision had to be made. Those sorts of things are all waste. Now, if you imagine the perfect health system, which does not exist, but you imagine building a perfect health system where you take what you've already got and you spend the time and effort to pull those wastes out of the system, imagine the productivity gains that you could get from your staff. Just imagine the efficiency gains that could be delivered, and imagine the improvement in patient experience that you could deliver as part of that. These are wastes that we all know are there in our everyday healthcare work. Continuous improvement is about bringing the time, the resource, and the focus on reducing those down and empowering frontline staff to do that. So before I go on any further, I should probably just make some definitions so that we're all on the same page about what continuous improvement is and what continuous improvement isn't. The King's Fund, the international healthcare think tank based in London, did a piece of work on continuous quality improvement at the end of last year, and they gave the definition that's here. I think we could all agree with that, but it's very high level. It doesn't actually tell us what we do. The way that I like to think about it is a bit different, and as you can probably guess this because I've alluded to it already, but those who are closest to the problems in healthcare, the frontline staff, are the people who are best equipped to identify them, and they should be the people who are best equipped to solve them. And how do they do that? This is the granular bit. Well, there's many different ways of building continuous improvement, and there's many different management mumbo-jumbo buzzwords around this. You've probably heard of lean, continuous quality improvement, Six Sigma and the like. But ultimately, they all boil down to the same thing, which in plain language is applying a systematic scientific approach. Iterative change. You've probably heard of incremental change that people are talking about in sports teams at the moment. Rather than trying to push to make the big leap, let's take all the little things that we can improve, because when you add those together, you gain the few extra seconds that make the difference between winning and losing. It's the same process, although people have tended not to make the association between the two. And it is scientific because it's testing and measuring and repeating until you've made the improvement, until it sticks, until it's right, until it works. And as I mentioned already, it's the frontline teams that are charged with doing this. Now, I mentioned earlier that I get the opportunity to look at a lot of different healthcare providers and different health systems to see what works. And while I would be the first one to pick many, 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 many faults with the US healthcare system, it is a challenging environment, like everywhere else. Despite the numbers, they are challenged in many different ways. And remarkably, in a paper very recently published in the last few months in the Journal of the Joint Commission by Professor Stephen Shortall, 69% of hospitals that they surveyed were using some form of continuous improvement methods because they recognise the benefit that can be delivered. The catch is how many of those hospitals make it stick over time. And that's the real catch. And that goes to the research that I'm going to talk about in a moment. So I've talked about waste. There is a question that needs answering about why. Why bother? Does this really deliver value? And I think an important thing to flag right now is that if you think about continuous improvement in terms of just delivering cost savings for your organisation, it's not going to work. Firstly, because that's not really the way that this should be thought about. And secondly, because if you pitch it that way, your staff, particularly your frontline clinical staff, will disengage because that's not their focus. Their focus is, number one, the patient. That's what we're all here for. But actually, if I can improve the patient's lot, and if I can improve my working environment, if I can see that I'm making efficiencies, and if I'm empowered and supported to do that, then I'm going to be more engaged. I'm going to feel more valued as a worker in the organisation, which brings its own benefits. And the other points here, you can imagine we've touched on some already. Time savings and timeliness to increase productivity are big points. But there's plenty of evidence showing that by taking steps out of processes, by firming them up, you can decrease the number of mistakes and errors that occur. Get all of these right, and the money follows. That's a really important point. Again, don't take my word for it. I was in Singapore last week. Many of you might have seen 2 weeks ago, Bloomberg published their latest ranking of global health system efficiency. Singapore, for many years, ranked as the most efficient health system in the world, got bumped down to number 2, replaced by Hong Kong. My lesson in that is it's much easier to organise efficient health system if you have a one-party democracy or otherwise, and you happen to work in a big metropolitan city. But glossing over that, Singapore is one of the health systems that's most widely adopted continuous improvement methodologies. So the majority of all of their public sector hospitals have implemented continuous improvement over a decade ago. So while I'm not trying to convince you of cause and effect of the link between those two, it's an association that needs to be noted. Now, I was in Singapore General Hospital on Friday. I took this photo. It's the largest and oldest hospital in Singapore, 1,700 beds. It's the leading academic centre. And when you walk into Block 3, they have a huge section of the wall given over to their staff and the work that they're doing around quality improvement. And this photo is just a small little section of it. I took it because I quite liked Kaizen, their ninja improvement mascot, and I was a little bit disappointed to find out the improvement team didn't actually dress like that. But you can see here, so these figures are from April 2017 until now. Really impressive. 70 staff trained not to deliver improvement themselves, but to coach improvement, quality improvement projects, to support the frontline staff who are doing it. Just over 350 staff who've been taught the general principles around this, the concepts of what quality improvement is, how to identify problems, how to establish your baseline data, how to use that to drive change, your PDSA cycles for testing that. And so since April last year, they delivered 105 improvement projects. They estimate they've saved over 15,000 hours of staff time and delivered nearly $250,000 savings in Singaporean dollars, which is $500,000 US dollars, 7.5 million rand. Really impressive, really impressive. Now, you could look at those lists of the value that could be delivered and think, oh, we can have a project team to look at those. In fact, many of you have probably got project teams in your hospital at the moment who are working on things like that. So what's continuous improvement? Why is it different? And this quote goes to the heart of that. Because you can have lots of team around your organisation, lots of champions, a few clinical staff, all doing popcorn improvement projects, randomly popping up for a while, not really necessarily coordinated, not moving the institution towards the direction that it should be going in, not coordinated. not supported. Continuous improvement is something different. It's establishing a management system that joins all of that together, so that from your frontline staff who are taught and trained and empowered right up to the chairperson, chair of the board in the organisation, from top to bottom, everybody understands what improvement is. It's everybody's job to deliver it, and everybody is supported in doing so. So it's not a pet project, not a popcorn project. It's certainly not a fashion. This is a long-term investment in the future, and it's not an isolated program. This is a new way of working for an organisation. And many of you will be familiar with perhaps the Toyota production system of how this was originally developed. It was a whole fundamental cultural change in manufacturing. And it's only now that we're really beginning to realise how that can be applied to healthcare. So what does a change in management mean, and what does it look like? Well, again, some of this will be familiar to you. On this side, we have the typical healthcare organisation. So you can see here, executives, middle managers, operatives, and the time they're spending. Most frontline staff are spending time on their day job, and a little bit of time gets spent on improvement in the organisation. Executives spend a lot of time firefighting. Now, we're all friends. Hands up in your organisation if you think you spend a little bit too much time firefighting. A lot of hands going up. More hands going up than were delivering continuous improvement. So what happens is this: because all of the day job is being taken up here at the bottom end, when problems arise, lots of little problems bubble up from the front line and overwhelm executive with minor issues. And actually that's kind of how we've always worked. It's what we're used to. We are firefighters, we're problem solvers, we're the heroes who come in with a solution. But what if we worked a different way? Now, I said already, the perfect healthcare organisation, a health system doesn't exist, but if it did, I'd like to think it would look a little bit like this. Improvement becomes everybody's equal job. Because the frontline are empowered to problem solve themselves, they keep those issues and they're resolved before they ever get up to middle management, let alone overwhelming executive management, freeing up much more space for the bigger strategic thinking that executives should be delivering. They can actually concentrate on pushing the organisation forward and what's required to do that, rather than being the hero who's parachuted in to problem solve every day. So let's think about the lessons that can be learned. So everything I've said so far, I suspect I wouldn't hear a lot of major disagreement with that. So where's the problem with this? Well, the problem is in implementing it and sustaining it. It's very easy to stand here and tell you about the theory. It's much more difficult to actually make change happen. You know, change is fine, isn't it? Absolutely fine, as long as it's someone else that has to change and not us. That's always the way that it is. So we spoke to 21 acknowledged healthcare leaders across 15 organisations in 6 countries, and we spoke to organisations who have been leading change through continuous improvement for a considerable period of time. Some of them are international leaders and widely recognised for doing so. And we asked them what their learnings were around, first of all, implementation, and then secondly, how you sustain it. And some of these have been doing this for over a decade. So there's a huge amount of learned experience that we wanted to try and collate and share to help people who are thinking about embarking on this journey, or those who are thinking about it, perhaps they've already embarked on it, but want to sustain it for long enough to be able to deliver the changes that it can bring. So we split this down into implementation and sustaining. And some of you might recognise some of the organisations that we spoke with: Sick Kids in Toronto, Mercy Mount Sinai in the US, Tang Tok Seng Hospital where I was in Singapore last week. Some of these are famous world-leading organisations in this work. And actually we heard very similar stories across all of these organisations about what works and about how to do this right. And we go into these in a lot more detail in the report, but I'll pick a few now to kind of explain a little bit more and explore what some of that means. I've mentioned already about rethinking the management system for an organisation, not process improvement teams. It's changing from a model of top-down command and control to being able to have a front line that are trained to identify problems and sort those themselves. So it's a fundamentally different way of working in an organisation. And if you try to bring some of the tools of continuous improvement and apply those onto your organisation without recognising that need for a different management system, you're almost guaranteed to not be able to sustain it, to not deliver the benefits, and at worst fail. But in order to do that, it requires very serious commitment from senior leadership. For once, it's change that they're not asking other people to do. It's change you have to do yourself. It's about being able to let go of that top-down command and control structure and place trust in your frontline and middle management to handle those problems without you having to get involved. They shouldn't come across your desk. A lot of time and thinking is required to get this right, point 3. And it's very important to strike a balance between implementation, which teams it's rolled out to, how the management needs to change its work, and how some of the tools to be able to achieve all of this are deployed. The important thing to bear in mind is that this has to be seen as a multi-year journey. This is no quick fix. It's an investment in tomorrow, is the best way of thinking about it. And so in some cases, if you're looking for a short, sharp change that's going to improve your organization, this isn't it. This is something where you need to go slow at the start in order to be able to then go fast and improve as time follows. Point 4 is a point that's quite close to my heart. I've mentioned several times, and I'll mention again that I'm no big fan of management mumbo-jumbo language. Particularly important for this sort of work when you're looking to engage the frontline staff who have to deliver it. And what we saw in a lot of successful organizations that we interviewed was that they gave this their own branding. They used terms, as I mentioned already, that are more about patient experience and staff experience than about any sort of cost containment, cost control improvement. Very important to get your language and messaging right. And successful organizations we spoke to had communications with their staff for up to 6 months before this was launched. And when I was in Singapore last week, one of the improvement teams that I was talking to, I thought encapsulated it particularly well, because if you go to the heart of what continuous improvement is, it's about giving your staff a forum for connecting and communicating about the everyday issues that they see in front of them. It's fundamentally about communication. And even if you get that communication right, point 5 still holds that by very nature, clinical staff can be somewhat suspicious of these sorts of initiatives, seeing them as a fad, seeing them as how on earth can the Toyota process be used to improve how we deliver healthcare? We don't manufacture cars. So you have to think hard, because so much of implementation is about the training, the coaching, understanding of the basic principles, and then getting people to actually work differently. That can be very challenging. Getting that right, particularly for clinical staff, is important. And the final point that we heard about implementation from all of the organizations we spoke to was the importance of demonstrating early impact with this work. And that might be in terms of how many problems were identified and actually put forward by staff. And some hospitals that I've spoken with actually set targets for their staff to do that. In a 1,000-person organization, imagine if everyone had the responsibility of nominating at least one objective improvement every month. And just imagine the potential gain of that organization if every member of staff managed to deliver on that with one solid improvement every month. When you think about it at that sort of scale, it's huge. But this does require new ways of working. So establishing what those early wins are and communicating them very clearly to staff and patients is really important to get this rolling. What about sustaining it once it's got going? Well, as I said already, many organizations fail at this hurdle. They get launched and it falters. They don't quite get the change that this promises, the benefit that this promises to them. So getting it to stick is important. And again, we heard 6 key points from organizations that we spoke to. Number 1, I think we are all guilty of in healthcare. Everything needs to be measured and improved increasingly. There are targets set by many different organizations, internal and external. But when you think at an executive level about an organization as a whole, really you could boil those down into a few key things. And you probably might still end up with a list of 10 or 15. But the difficult thing is then, out of those, prioritizing what the key 4 or 5 are that you're going to stick with and make your priority, your organizational priority for 12 months. Because some of these are big and sticky problems, and lots of little improvements might help get you there. But if you're going to fundamentally move the needle on something big, it takes time and commitment to stick to it. And there's a lot of work involved around this. Getting an executive board to agree on a short number of priorities, my goodness, that is not easy. And actually understanding the data that your organisation has to help in that prioritisation process is not necessarily easy either. The second point was the need to embed at all levels. I've talked quite a bit about executive leadership. I've talked a lot about the front line. Most commonly we heard from organisations that there's a missing middle, because it's absolute glue, the middle management, between communicating the executive objectives and being able to coach the front line to solve these problems themselves with a bit of support. So perhaps the person who needs to change their way of working the most is that middle manager, but often they're the person that doesn't get all of the executive coaching, and they don't get all of the frontline teaching and training. So rather than looking at the bookends, it's really important to make sure that middle management understand the change process and are supported in it as well. Point 3 was a term, and this is the one bit of this management language I use, is true north. And I like it because it differentiates between the magnetic north, the direction you kind of get pulled in, but it's not actually where north is. But agreeing through your organisation what that north is fundamentally important. Your staff have to understand what you're all working towards. Is that reducing falls, reducing surgical site infections? Whatever that quality improvement is you're working towards, the front line has to be aligned with the overarching objective that's been agreed, that priority that you're all going to stick to. Point 4 was an interesting point that we heard from several, but not all organisations, but it's the need to empower and engage patients in this work. Now, if you are having a meeting talking about problems in a healthcare organisation, the knee-jerk natural reaction, I think, of most medics and managers is to keep your dirty washing out of patients' sight. And so this is very counterintuitive, but actually engaging and empowering patients can be a really strong tool for helping your staff carry this forward. And often they don't see it as dirty washing, although that's how we envisage it. Often the message that they get is that they're impressed that we are measuring the extent of problems we've got, that we're actively discussing and working to improve. And so getting them involved and harnessing patient power in this is a really important, largely untapped resource. Point 5, digital technologies. Only time I'm going to mention digital technology in this talk. I was talking to a hospital chief executive in New York, and while I can't do his gruff New Yorker accent, it'll probably sound South African if I try, I actually found he said something really fantastic. And he said, you know, how much digital can support. Digital can really help support by giving you dashboards of your outcomes, give you real-time data on your achievement. But the point he made was, but you better get your house in order first. And the reason is, so often we use technology as a sticking plaster. But unless you've fundamentally got your house in order first, unless you've got a management system in place that can take it and implement it and benefit from your digital generic initiative, then it is just a sticking plaster. And indeed, one of the major hospitals that we spoke to in Toronto, they were due to implement a new electronic health record, and they held back several years until continuous improvement was embedded, so that when they came to implement an EHR, which any hospital that's doing it will know is a major step, that they had the right management system, the right tools, the right techniques, the right culture, the right way of working to then be able to troubleshoot the EHR implementation. And that was a bold move, but a very successful one ultimately for them. And the final point, I touched on this already, is that this is not a quick fix. You have to allow time for an organisation to adopt this new way of working, to adapt, to improve. And that can take several years to get to that point. But it is fundamentally an investment in future. And the one point I want to hammer home for a second is to come back to this point around leadership in all of this. In every organisation we spoke to, the leadership was absolutely pivotal in identifying that there was a need to do better, in seeking a way to do better. Many organisations were failing and they knew it and they knew they had to change. Several organisations we spoke to were already world leading, but they had an appetite to make themselves better and were looking around internationally to see what could they do to take themselves to the next level. That leadership needs to give clarity of purpose. It needs to give stability over time, to stick with this over the years. You need to have the right staff on board who have experience of this, who've spent time looking at what's involved and are up for that level of change and are able to commit the amount of resource that's required from an organisation to deliver this. Without leadership being on board, implementing and sustaining continuous improvement will not happen. So quickly, I'll just think about change. It's where we started. It's the questions I asked you at the beginning. We did a piece of work a few years ago now, looking internationally at 65 health leaders, and you'll see here that what you told me at the start is replicated around the world. When we did this survey, you can see that nearly 3/4 of healthcare leaders thought that fundamental change was required in the health sector in their industry. But when we asked them whether it was their organisation that needed to change, only 1/3 thought so. Change is great, as long as it's always someone else that has to do it. And recognising that it's us that needs to change in the way we work and how we deliver it is really fundamentally important. But then that leads us to ask, well, how do you actually do it? And so my final points are really just to think about how you build for the future. Points on the right here are really what hospitals, good hospitals around the world are thinking about. And you need to be careful that the tail doesn't wag the dog on these. Technology, data analytics, process and operations are there to serve, but not to dictate. And actually, we need to spend our time thinking about the vision, the strategy, the culture and the organisation, particularly the patient experience and staff experience, in order to then dictate how our process and operations work, how we use data and analytics to think about new ways of working, and how we implement technology to support that, and not to be the tail wagging the dog. And I think time and time again, we heard from organisations we spoke to, I don't think there was a single one that hadn't been somewhere to see what a successful organisation doing this looked like. Being able to actually visualise it and hear from the frontline staff themselves is probably the most powerful tool you've got to learn if you're thinking about doing this in your organisation. I'm not going to talk much about how we support that. I'm very happy to have a conversation separately. But strategy deployment, the building of the management system, delivering some of the actual operation improvements and supporting them, and building the centre of excellence so that this work becomes self-sustaining inside the organisation, just as the General Hospital has done in Singapore, are some of the areas that we find ourselves working globally. Our report is being published this week. We already have some materials online. I'll be very happy to share the full 50-something pages when it comes off the press later this month. It'll be a good read, I hope, when you see it. And I'm very happy to have a conversation in more detail about some of the more granular aspects of what this involves and what we've seen internationally. But I'll finish with a final point, taking me back to Kilimanjaro, because I realised as I was heading up this godforsaken mountain that so much of this sort of challenging work is mirrored in what we do with continuous improvement. It's about the team. It's about the long haul. It's about having a vision, a clear picture of where you're aiming to get to. And it's about understanding that it's going to take a lot of time to get there. But I'll tell you, when you get to the top, the view for your organisation is absolutely worth it. Thank you very much.